So this forum is kindly being taken by 3 first years who've taken up the gauntlet to present some cases. Now, the remit was basically to look at some acute ultrasound, which we've been starting to do this year as first years, because they're obviously going to move on to have to go on to the on-call and move up to become more senior. So they are going to present a few cases on a topic or a sort of theme that they have found in ultrasound, or the other registrars they've been involved in, that they've found interesting and that they've taken some teaching points from. So as first years, you might think, well, you know, it's an ultrasound, I might not be involved in this, but actually it's really good for us to have a refresher, and it's really good for also any other registrars that are here listening in tonight. Hopefully they'll have a refresher on some subjects as well. So we've got Priya, we've got Alex, and we've got Michael Morgan. They're all going to do, I know, a fantastic job. So I'm going to hand over to them and say thanks. And who's going to go first, guys?
Hi, thanks, Penny. This is Alex. So I'm going to go first.
Hi, Alex.
I'm just going to share our screen here. I'm using Mike's laptop in case it seems that I'm pretending to be Mike. Can I just check you can see the presentation?
Yeah, I can see the presentation. Hopefully everyone else can.
Great. So I'm going to present a couple of cases of which came in to the ultrasound on-call list, which are testicular pain. So I think that hopefully these cases will demonstrate the importance of ultrasound in imaging and investigating this indication, and some of the value that we can add in ultrasound to the clinicians. So just very quickly, I'm going to run through the main differentials and reasons that we might be scanning testicles in the department on the on-call list. So probably the most important but quite uncommonly seen diagnosis that we might get through is a torsion. So a lot of the scans that we do, the acute testicular pain, will be a query torsion in order to really just rule out that it could be this, because it's quite a time sensitive and potentially could cause the loss of the testicle. So the main things we're looking at there is decreased vascularity of the testicle. Probably the most common thing that we see as a cause for testicular pain is infection. So infection of the epididymis or the testicle, or commonly both. There we might expect, as in other regions of the body, to see increased vascularity in the testicle and other secondary signs of infection, edema surrounding potentially abscess or collections. Otherwise, we might get scans through for trauma, so hopefully there'll be a history there of either injury or surgical intervention, and occasionally, probably uncommonly, malignancy can cause pain. I think probably only about 10% of testicular tumours present with pain as a symptom. So we'll start with the case. So this was a 43-year-old male who initially went to his GP, who referred him into A&E for testicular pain. So 4 hours, just gradually getting worse over the course of the day without really having any clear trigger. He did feel some nausea as well, but he wasn't vomiting. Previously reported what he'd called thrush, seemed to have been treated about 4 months ago. It's unclear whether this was an STI or not from the notes, but probably relevant to know. So on examination, they found a slightly enlarged right testicle with focal posterior tenderness and of the upper pole. His OBS were all normal, and there was no relevant positive findings from urinalysis or his bloods. So in the indication, the clinicians felt that most likely this patient had epididymitis, but wanted to rule out a torsion. So they asked for an ultrasound. So the first thing that we would do, well, talking about the basis of the scan, so We use a high frequency linear probe for the testicular scans. There's some fine anatomy and fine structures within the testicle that we want to get clear resolution of. They're all quite superficial, so the high frequency probe is most appropriate for this. A good thing to start off with is to compare the left and the right sides. So to get an idea, you might have from the history which side is abnormal, but to get an idea of what we're looking at, it's quite crucial to compare the sides, and we'll see that later. So just looking at these images here, can you see, I think you can see my mouse cursor here. So the left testicle here and the right. So the right does look slightly enlarged compared to the left. It's not always easy to get good views of the right and the left next to each other just because of the line scrotum and if the patient's very tender. But we can see that in general, reasonably similar echo texture between the two, but the right does look slightly enlarged, and it was very tender on scanning. So having a closer look at the left testis, which is the normal one, we've got long and transviews here, quite normal volumes and sizes of the testicle, very normal appearances. And we'll just have a look at the right. So here you can see I've got the left testis here just for comparison, and here is a trans and a long view of the right testicle. So we notice on this, first of all, that the right is larger as we suspected from the previous view. So it measures 19 centimeters cubed in volume as opposed to 13 on the left, which is not necessarily an enlarged volume, but it is bigger than the left side. So that's something to bear in mind. I think we also notice that the echo texture on the right is quite coarse. You can see patches of increased echogenicity here and some patches of hypoechoic parenchyma as well. So that tells us that there's probably something going wrong within the testicle there. The other thing you might note on this is a small trace of fluid within the tunica vaginalis. So that's a small hydrocele. So the next thing that we probably would be prompted to do after seeing this would be to put on the colour Doppler. So here we can assess testicular flow, blood flow. It's quite clear from these images that there's good flow, normal flow within the testicle on the left, but on the right, it's very patchy. You almost say absent. It's difficult to say from still images whether this could be just motion artifact, but the subjective opinion was that it's pretty much absent on the right side on the colour flow. It'd be important doing these to try and make sure you've not changed the settings between the testis, because that will make the comparison more valid. If you change the sensitivity and things in between those images, then it would be difficult to actually make a direct comparison like this. I'll just highlight here, you can see again a bit of fluid around the testicle. This image shows the anatomy quite well, so you've got the tunica albuginea and vaginalis here with fluid in between. I'm going to have a look more at a few more images to interrogate the flow between the two testicles a bit further. So here we're looking back at the spectacle view that we saw first, so the left and the right here. It's good to get them both in a single image or colour box. Gives you confidence that you're making a valid comparison. You can really say here that the right testicle has reduced flow compared to the left. We're looking at centripetal and centrifugal arteries within the testicle. So this is one of these. It's difficult to say from this image which that could be, but we can see a good flow down to the left testicle, whereas pretty much absent flow on the right there. So going further, we've got other options that we can use to interrogate the blood flow. This image is power Doppler. So that's going to take away directional information that we get with the colour Doppler and just give us a bit more sensitivity for flow. So it's better for imaging small vessels with low velocity flow, which is very useful for the testes. where we won't always necessarily get good colour Doppler flow, even in the normal case. There are other techniques such as SMI, which we have in our scanners as well, which can give you a bit of directional flow as well, and a bit more information about small or low velocity flows. So again, looking at these images, you can see you've got reasonable flow within the left testicle and essentially absent flow within the right testicle. And again, you can see the coarse and heterogeneous parenchymal texture there. So having scanned up to here, we've got certain ideas in mind about what's going on. So we're going to then assess the contents of the hemiscrotum a bit further, have a look at other structures to try and get a bit more evidence for our opinions. So here we've got the spermatic cord, which is a complex structure conveying arteries, veins, the vas deferens and lymphatics down, as well as nerves down to the testicles and back up. So we're going to try and have a look there and see if we can define a cause for the reduced flow. So here you can see the structures of the spermatic cord. There's a bit of fluid around the spermatic cord, which indicates that this is probably a site of potential wrongdoing. I'm going to move on now to just show you a video, a cine loop of scanning through there, through that region, so from inferior to superior. Hopefully this is going to work okay. So you can see from the body marker here that we're scanning in this trans plane up through the testicle and spermatic cord. Go back to the start, you can see a bit of fluid around the testicle there, and then I hope that you get some idea of this swirling of the contents of the spermatic cord and some layering of the contents of the spermatic cord. So I'll play you again. And this is a crucial sign to recognize if present in scanning testicles, particularly when there's a concern for torsion. I've got another video here just to show you that. Again, if you are able to notice, there's an apparent twisting of the contents here, which we refer to as the whirlpool sign. So I'll move on just to summarize what we've seen in this scan. So there's an enlargement of the right testicle with a heterogeneous echo texture, both hyper and hypoechoic patches within the parenchyma of the testicle. We've been unable to detect any significant Doppler flow within the right testicle, and we've noticed this swirling of the spermatic cord. And the right testicle is very tender on scanning as well, and a slight hydrocele. So you probably come to the conclusion that this patient has a torsion, which is correct. So the patient was taken straight to theatre, and on operating, surgeons have reported that the right testis was torted 720 degrees around the spermatic cord. So I think that the findings there were unsurprising, and probably the ultrasound images with pretty much absence of flow, as well as the heterogeneity of the parenchyma, would make us quite concerned that that testicle was not going to be viable. However, they did detort the testicle manually in the operation, and they found that it pinked up pretty immediately, and they felt that it was viable. So they did just fix that testicle in place. They also found the left testis was half twisted as well, 180 degrees. So they fixed that side as well. And there was a bilateral bell clapper deformity, which we'll move on to discuss. So just going to talk a little bit about testicular torsion and how it relates to the case. So it is a time-critical emergency presentation, which is why getting the ultrasound and acting upon it is essential. So within the first 6 hours or so, salvage is very successful, up to 100%. Often, however, patients present quite late and go through other routes, such as their GP, which adds delay to proceedings. And then they've got to actually have the ultrasound if there's clinical uncertainty. So it's quite important that if we do get these through and there's clinical concern for torsion, that we scan them as soon as we can. In this case, the indication wasn't actually for it wasn't suspected that torsion was the most likely diagnosis, and yet it was a pretty severe torsion. So it just shows us the importance of having the ultrasound if there's any degree of clinical uncertainty. As after 12 hours, the salvageability of the testicle becomes very limited. Predisposing factors to cryptorchidism and the bell clapper deformity that I've mentioned, this patient had bilaterally, which happens in about 40% of cases. It will be bilateral. So that's where the tunica vaginalis attaches, which is the purple here, attaches high up on the spermatic cord and just allows the testicle to freely swing and rotate within the scrotum here, which can lead to torsion. So the ultrasound findings that are typical, pretty much all seen in this case, the absence of Doppler flow, slight enlargement of the testicle, parenchymal changes tend to be hypoechoic, heterogeneous echotexture first, and then develop hyperechoic foci with necrosis and hemorrhage. And swirling of the spermatic cord, the Whirlpool sign, is reported to be the most sensitive and specific finding in testicular torsion. Got a slide here that just shows we don't often take waveforms of the testicular vessels, but if there is uncertainty around it, you can take waveforms, particularly because sometimes the only sign of testicular torsion in the early case or in a partial torsion would be an abnormal waveform. So here we can see an example of high resistance to flow, and we've got diastolic flow reversal there, which would be a concerning feature. Some of the pitfalls, that's one of them. So there you're looking at asymmetry, so it can be difficult to know whether you've got high flow in one testicle and that's abnormal, or if it's actually low flow in the other testicle. So the waveforms can help in that case. Intermittent torsion, where it presents with symptoms that come and go over the course of a few days or weeks, and can appear normal otherwise. You've then got hemorrhagic complications of torsion, which gives you hyperechoic areas and a patchy appearances, which can sometimes resemble focal lesions like tumours. And you've got other reasons for there being absence of flow, such as venous infarcts, which is a complication of epididymitis. So you'd be looking for other findings that support that diagnosis as opposed to the torsion. And again, the Whirlpool sign helped to clinch it in this case as a torsion. So I'll move on to case 2. Which is a 23-year-old male, so a young man, which would be the right demographic for a torsion. 6 or 7 days, however, intermittent right-sided testicular pain with some lower abdominal pain. On examination, his right testis was found to ride quite high in the scrotum and horizontal, and it was mildly tender to touch as well. Otherwise, no positive findings. So in this case, again, the most likely diagnosis by the clinical team was probably epididymoorchitis. So they were wondering whether they should just treat him with antibiotics and wait. But there was also a slight suspicion, because of the pain, possibly an intermittent torsion. So we'll have a look at some of the images. So here again, we're comparing the right and left, but this time we see there's a stark difference in the parenchyma between the two sides. So we can see the right side is quite hypoechoic with abnormal appearing tissue, and again the left side looks quite normal. So we move on and get our longitudinal views of the testes, and here we can see the right testicle is very abnormal. So there are these hypoechoic rounded lesions here, some hyperechoic foci. Looking here, possibly a cystic region with hypoechoic, very low signal, and there's a hint of some shadowing beneath these slightly hyperechoic foci there as well. So we're wondering if there's calcification as well as some cystic change here. You can see the lesions are all contained within the testicle. There's no exophytic component, and they're quite smooth margined. So some of the things that we could have done here to clarify whether this was calcification would be to take off the compounding, which just enhances artifacts such as the shadowing, and we could have put Doppler on and seen if there was any colour twinkling or speckle from calcification within those lesions. So then, having seen this, there's a few things that would run through our mind. He is complaining of slight tenderness. We'd have a look at the epididymis. Here we can see the right side epididymis, not particularly vascular. It looks normal inside, and when we compare to the left, you can see a couple of cysts here on the left, but it looks quite normal. So we're not really finding positive findings from the epididymis. But again, it shows just how important it is to compare both sides. So we move on with our Doppler to the actual lesions within the testicle themselves, and here we can see quite clear penetrating small blood vessels within the lesion. Having a look at that from a few different views, I think we're now quite convinced that this is a lesion that does show vascularity, albeit quite focused and appearing to have these feeder vessels into the lesion. We could again have used power Doppler to get an idea of the general perfusion of the lesion here. So to summarize, we've got multiple heterogeneous vascular lesions within the right testicle. Again, there was a trace of a hydrocele, but the epididymis looked normal. So our main concern, given these findings, is probably that there's a tumour or tumours within the right testicle. Again, this was referred to on the indication as clinically epididymal orchitis, which is something that may be treated with antibiotics without any further particular investigation. So I think, again, it just demonstrates when you've got this diagnostic uncertainty, how important ultrasound can play, how important a role ultrasound can play in preventing any harm and just making sure that we find these rare occasions. So the outcome, he had a CT scan, there was no nodal or metastatic disease, and the tumour markers at this point were not raised. They did find the mass within the testis, and on histology it came back as a seminoma. Looking back at the ultrasound report, at the ultrasound findings, the smooth margin and the hypoechoic contents of the lesions support or would be commonly found in a seminoma. Occasionally calcifications and cystic changes may be found in seminomas, but it's less likely than other tumours. But the fact that it was contained within the testicle with this smooth margin, not exophytic, to support seminoma over other types of testicular tumours. So finishing up, I hope that being able to demonstrate how important it is to get the ultrasound in these cases and how much of a effect they can have on making the right diagnosis where there's clinical uncertainty. I think that these cases were diagnosable quite, we were able to come to a conclusion from the ultrasound reports without too much difficulty. They're quite classic cases of both. But if there is difficulty, having looked at the ultrasound images, comparing both sides is extremely useful. So it can be difficult to identify which side is abnormal if you've got one which appears to have increased flow compared to the other, and that's where the Dopplers can come in useful. Torsion can be confused with a venous infarct, which can occur as a result of epididymitis. Both result in decreased flow to the testicle. So there it's crucial to have a look at the epididymis and see whether or not images there support either a torsion or an epididymitis diagnosis. Complications of a torsion, such as hemorrhagic changes, can also become quite mass-like and tend to resemble tumours, as can abscesses within the testicle. So using the Doppler and looking at the waveforms is very useful in that too. Occasionally, tumours can occupy the entire testis and distort the anatomy quite significantly. And again, that can make it very difficult to distinguish between tumour and abscess and hematoma. So again, the Doppler imaging, ruling out or at least assessing the blood flow to different parts of the testicle and the epididymis can really help you to distinguish between those different etiologies. So I'm going to finish up there and hand over to Mike, I think, who's going to discuss some more cases. I'm not sure if we're taking questions at the end or after each one.
Shall we take questions at the end just for constraints of time? But thank you for a lovely presentation. I love the cine, and I think, you know, the fact that you've got such lovely pictures of that whirl sign as well, which often, you know, we get in ovarian torsion as well. So really important, that torsion case. So Michael, thank you very much, and take it away.
I'm just going to share my screen once more. Can we see the presentation?
Yes, I can.
Now, so I'm going to be talking today about a general theme about right iliac fossa pain, with a particular focus on appendicitis. So we can start with a cine loop here of a normal appendix, just because they are fairly rare to find, but a nice tubular structure running alongside the psoas muscle here. And it's classically described, the appendix, as having a blind end. That's a feature that you need to look for in trying to find the appendix. We have another nice still image here of the terminal ileum lying alongside the appendix. And feature of a normal appendix is compressibility, which are demonstrated in these two still images here. Now that we've seen what a normal appendix looks like, we can talk about some of the features of acute appendicitis on ultrasound. So I've stolen this table from Mosbeck et al., but it demonstrates the differences between the direct and indirect signs of acute appendicitis. They talk about non-compressibility in acute appendicitis, so the appendix does not compress. The diameter of the appendix greater than 6 millimeters. There's a description of a target sign with a hypoechoic fluid-filled lumen, a hyperechoic mucosa around it, and then another hypoechoic muscularis layer. There can be the presence of an appendicolith, which will look hyperechoic on ultrasound, with posterior shadowing, and you can use your color Doppler to occasionally see mural wall hypervascularity. That's not always the case, and we'll discuss that in a bit. There are also indirect signs. You can see free fluid in the right iliac fossa, occasionally local abscess formation, increased echogenicity of local mesenteric fat, and occasionally some reactive nodes. I've got a nice cine loop from one of the Registrars that demonstrates some of those features. So again, we have a tubular structure coming off the terminal ileum. It looks like it's got a bit of a bigger diameter than the last one. There's some free fluid around it. And again, it ends in a blind, again, it has a blind end. We'll go through that one more time. You can see this appendicolith there too, with some posterior acoustic shadowing. And it comes along, nice blind end. We have some stills next. So here, we need to measure and see that the walls are greater than 6 millimeters. We've got a measurement of just the appendicolith here. It shows it's 11 millimeters, so we're fairly confident the diameter of the appendix is greater than 6. This is just a nice long image here where you can see the appendix and its blind end, and that fecalith again with the posterior acoustic shadowing. And our registrar today has put some color Doppler on, and we can see that mural hyperemia and some of that free fluid once more. So what are the causes of acute appendicitis? Generally, there's an obstruction. Those can most commonly be caused by fecalists or foreign bodies. Pediatric patients, you can also get some lymphoid hyperplasia. Rarer causes include strictures, parasites, and malignancy. So what happens when you've got an obstruction, because it's a blind-ended structure, obstruction persists and causes high intraluminal pressure due to all the mucosal fluid production. That carries on, and you can get a temporary period of ischemia. There you won't see that mural hyperemia with the ultrasound probe. As it continues, the intraluminal pressure can build and occasionally perforate the appendix. The appendix can go necrotic at that end, and at that stage too, you won't see the mural hyperemia. So there are, at the beginning and the end of the appendicitis process, periods where you might not see that classic mural hyperemia. So we'll get started on some cases. The first case is a 43-year-old male patient. He's had a weak history of right upper quadrant pain. He's apyrexial. His CRP is 25, so a little bit raised, and the ED have asked for an ultrasound abdomen query gallstones. Our registrar decides to put a curvilinear probe on the abdomen to look at the gallbladder, and they think it looks pristine. So they ask the patient if there's any other pain anywhere. They take a bit of a bedside history, and the patient says, well, actually, there's pain going down into the right iliac fossa. Not in those words, but he hints that there's pain there. So our registrar extends his search and finds the appendix quite quickly. And we've got what looks like an enlarged appendix diameter measuring 8.5 millimeters. So that's one of the signs of appendicitis. We've got some free fluid. And on this image here, maybe I can convince you that's some hyperechoic mesenteric fat. There's some secondary features there of appendicitis. We've got this. Registrar now wants to prove that it's a blind-ended structure, so takes a cine loop and loses it. And they lose it because the appendix is now going retrocecally, which is one of the most common positions of the appendix. It's coming back and around. So the registrar writes that in there, or annotates it on the ultrasound image, but doesn't write it on the report. The patient gets taken to theatre for a laparoscopic appendectomy by the surgeons. Unfortunately, the surgery doesn't go as planned because of the retrocecal nature of this appendix and the fact that it's now adhered to the sigmoid colon. They find it quite difficult to mobilize using a laparoscopic approach and have to convert to open. So I think some learning points for me from this case were the importance of a bedside history. 2, to appreciate the various positions the appendix can find itself in. And there's some evidence to suggest that a retrocecal position actually increases the risk of having to convert to open laparotomy, despite the retrocecal position being the most common to find the appendix in. So I wonder if you can gauge where it's lying via ultrasound, if it's worthwhile putting that in your report too. I think looking at the echogenic fat as a sign for secondary appendicitis is also very useful and something I haven't been doing but will incorporate into my practice. Now, the appendix doesn't just lie in these positions, it can also find itself in some rarer places. One such is within an inguinal hernia, and that's termed an amyand hernia. That's where you've got incarceration of the appendix within an inguinal hernia. It's named after Dr. Claudius Amyand, who is a 17th century French surgeon. And he was actually the first person to perform an appendectomy, I believe a successful appendectomy. These are very rare phenomenon, and they're useful to find them. It can be quite useful to use a higher frequency linear probe. And I've got some CT images here taken from Dr. Penny, actually, from one of her on-calls. We can see the appendix coming off here, finding itself within the inguinal hernia, within an inguinal hernia. In this case, there wasn't any acute appendicitis, but I've taken a case from Mebus et al., which shows the features of an acute appendicitis within the inguinal hernia. So that can be due to strangulation of the hernia and therefore the appendix, or because of sort of normal phenomenon causing an appendicitis and obstruction within the lumen. And here's an image of an amyand hernia on ultrasound. We've got the appendix there, and some free fluid around it. So the amnion hernia isn't the only place, so the inguinal hernia isn't the only place the appendix can find itself. It can also travel and locate itself within a femoral hernia. This is termed a de Garingeau hernia. Again, they're very rare phenomenon, and funnily enough, it's named after another French surgeon from the 17th century. I won't butcher his name again. Rare entities, and once more, a high-frequency linear probe can be very helpful in finding them. And I think in these cases, asking the patient where the pain is might help you locate where this is, because it might not be right iliac fossa pain. This is just another cine loop of de Garingeau hernia. You can follow the appendix coming down. It goes within a femoral hernia there. Let's play that one more time. So we'll move rapidly on to case 2. Here we have an 18-year-old female patient with a week's history of RIF pain. She's apyrexial. Her bloods look normal. She's got a negative pregnancy test, and she's also had a negative ultrasound abdomen 2 days prior. They're asking for another one. Our registrar dutifully scans them, and using a curvilinear probe, spots a tubular structure, not as enlarged as the previous one, but has a hyperechoic structure, within it, with some posterior acoustic shadowing, likely an appendicolith. We do another one. We scan through again, and we see another appendicolith. So we've got multiple stones in this appendix with pain. However, we don't really have many of the secondary or indirect signs of appendicitis. There's not much free fluid. Unfortunately, we don't have a cine loop of this patient, which would have been useful to see. And we're going to look for some mural hyperemia, and there isn't really any convincing mural hyperemia here. But our registrar says that these are some equivocal findings of appendicitis. The surgeons, because of the pain, decided to take the patient to theatre, and pathology proves that there was in fact an acute appendicitis. So this is an inflamed appendix without many of those secondary features of appendicitis, just had isolated appendicoliths and pain in the area. And remember, they had normal bloods as well. Some of my learning points from this case were that there are multiple features of acute appendicitis. Not all have to be present for you to alert the surgical team. Negative inflammatory markers do not rule out appendicitis, and use cine loops, I think, wherever you can, because there may have been more fecalists that you could have reviewed retrospectively after your scanning. And finally, I'll move on to case 3, which is a 56-year-old female patient who's had a 4-day history, had 4-day histories of right iliac fossa pain. She again is apyrexial. Bloods are fairly unexciting. The team are asking, is there appendicitis? So we're using a curvilinear abdominal probe. The registrar notices some free fluid, so we may have some secondary signs here of appendicitis. We detect a tubular structure that might fit with an appendix. We continue scanning. We've got the appendix here in trans. It looks fairly normal. It may be a little bit dilated, but there's nothing about it that looks particularly angry. However, we've got that free fluid. Our registrar thinks that maybe there's something else behind all the free fluid, so extends his search and examination into the pelvis, where they take this cine loop of the right ovary. It's not a great image of the right ovary, but there's something in the background there, which we'll play again just to have a look at. There might be a hint of a hydrosalpinx there. So our registrar in their report talks about the sort of equivocal features of appendicitis, but also mentions that there is some right hydrosalpinx. So when the surgeons take the patient to theatre, they alert the gynae team too, who are around. They see what looks like maybe early appendicitis. They remove the appendix, but the gynecologists get involved and notice that there's a torted right ovarian cyst. The entire ovary is now necrotic. It's removed. And in this case, the pathology showed that the appendix was actually normal. All of those secondary signs were likely coming from this torted right ovarian cyst. I think for me, this case really highlights the dangers of satisfaction of search. It was really good that the registrar saw the secondary features, saw that they didn't quite line up with how the appendix actually looked, and then continued their search into the pelvis, looking at both of the ovaries there. I think once again, try to use all of the tools available to you on the ultrasound. Looking for that mural hyperemia may also have been useful. We didn't have an image of that. So I think another point about looking for the appendix is it is hard. It's very hard to see the normal appendix, and the literature quotes rates as low as 30% to find a normal appendix. Rates for finding an appendix that is inflamed are higher, and they vary between sort of 40 and 70% I found in the literature. But there was a study by D'Souza et al. In 2014 in Winchester, which demonstrates that even in cases of appendicitis that went to appendectomy, the appendix was not visualized in 45% of the scans. And they mentioned that they thought that a structured approach to ultrasound scanning may help increase those rates of pickup. So what I've done now is just listed what I use as my sort of search pattern to find the appendix, and I feel like it's helped me during my scanning. So what I do is I take a curvy linear abdominal probe, start in the right flank, identify the ascending colon. You can do that by turning the probe long and looking for haustra. The ascending colon will also be highly echogenic due to the bowel gas. Then go back into transverse scan caudally to find the cecum, scan off the inferior margin of the cecum, come up again and start looking for the terminal ileum. It tends to be slightly less echogenic because a little less bowel gas. It also won't contain haustra. Once you've done this, you can then switch to a higher frequency linear probe and look for secondary features of appendicitis in the area, any fluids, any reactive nodes. Once you've done that, come back to the terminal ileum and try and find the ileocecal valve. The appendix should be in close proximity to this as it comes off. Some advocate for the use of 2 hands for fine motor control, but I don't do that personally. Just one more time, I'll show you an image of that nice normal appendix coming off the terminal ileum, running alongside the psoas, and then disappearing with its blind end. So to conclude, some of my take-home messages. I think visualization of the appendix is tricky, especially if it's normal. I believe a stepwise approach is useful, at least for myself. There are both direct and indirect features of appendicitis. Try to look for all of them, document their absence or presence. It's worth being aware of all the different positions of the appendix. I would probably, if you're confident, include that position in the report. Try to avoid satisfaction of search. And I think always a little pre-examination of pre-ultrasound history can be very valuable. Thank you very much. I'll pass it on to Priya now. I think she's operating off a different device, and there may be a minute intermission.
Fantastic. Thank you very much, Michael. That's absolutely brilliant. And again, those cine loops are really amazing to see, really helpful, especially if you need any scans reviewed or when you're writing a report to just go through everything again. So thank you for that. So Priya, we'll see your cases now.
Perfect. I'll just share my screen now. Thanks. Okay, perfect. So today I'm going to be talking about the vomiting infant. So I hope you've all got some stamina for a couple more cases. I think these tend to instill fear in the registrar because we start our ultrasound on calls before having done a pediatric rotation. And I think infants in particular can be very difficult to scan because of their small size. They move a lot, they cry, the structures are small, and they're often accompanied by pretty anxious parents or members of staff. So I guess just a little reminder that vomiting is really common in the neonate and it's non-specific, but by and large, most causes are self-limiting and can be managed conservatively. So just because a vomiting neonate has cropped up on your ultrasound list doesn't necessarily mean that you're going to find a rare congenital abnormality, and that's always worth bearing in mind. That brings us nicely onto case 1. So I've highlighted the important bits of the history. But essentially a 4-week-old infant presented with a 1-week history of projectile non-bilious vomiting after feeding. That vomiting worsened throughout the week, and on admission, the child was very dehydrated and distressed, but the abdomen was soft and non-tender and not distended. His blood gas revealed a metabolic alkalosis. His NG aspiration yielded light yellow aspirates, and his sort of prior history was pretty unremarkable. This is the initial ultrasound image. It was taken with a high frequency linear probe, and this is showing the upper abdomen here. And it shows a thickened stomach pylorus, and it's really hypertrophied as well. The registrar scanning this didn't visualize any stomach contents passing through the pylorus during the scan, which lasted about 10 minutes. So to orientate everyone, I've just sort of provided an annotated version. So here you can see the pylorus at the top. Here, this darker bit here is the muscle, and the mucosa in the middle. The gastric antrum is over here, and the gallbladder is an important landmark, actually. So that's why I've labeled it as well. Now, the registrar made 3 really important measurements, which does cinch the diagnosis. So there's the transverse diameter of the pylorus wall, the total transverse diameter, which is here, and the length of the pyloric canal. Okay, so I think you've probably all guessed that this is a case of hypertrophic pyloric stenosis. This is one of the commonest acquired causes of an acute abdomen in the neonatal period. And the key is that the vomiting is projectile, and that's due to the muscle hypertrophy, causes a near complete or a complete gastric outlet obstruction. Now, this doesn't present at birth, so you won't be getting a sort of 0-day-old or 1-day-old baby. It's usually about 4 to 12 weeks. This varies a little bit in the literature. Tends to affect the firstborn child a little bit more, and the classic textbook blood gas will show a hypochloremic metabolic alkalosis. So I've got some top tips for the registrar on call, which does really help with performing these scans. So the first thing is getting the infant in the right position. It does help to have the right side down. That tends to bring the pylorus right into the midline, makes it easier to see. You'll want to use a pediatric probe, which is a high frequency linear probe, and you'll position that in the upper abdomen and obtain your standard views, sort of transverse and longitudinal. If you are struggling to find the pylorus, it's helpful to locate the gallbladder, and then you could actually just sort of scan superiorly and inferiorly until you find the pylorus, or adjust the probe so it's slightly obliquely sagittal to the body. What you're looking for is a hypertrophied muscle, a fluid-filled stomach, and for no passage of stomach contents through the pylorus at all. There are some other eponymous signs, which I'm not going to go into at the moment, but one of those that you can find on ultrasound is the antral nipple. One way of remembering the measurements for the wall, which is sort of diagnostic for hypertrophic pyloric stenosis, is by remembering the numerical value pi. The first 5 digits are 3.1415, and those correspond to the sort of upper limits of these different measurements, below which, the pylorus would be considered to be normal. So the transverse diameter of the single muscle wall, which I showed you on that previous slide, is the most sensitive and specific measurement. And so if that's greater than 3 millimeters, you have to have quite a high suspicion that you're dealing with a case of pyloric stenosis, but also there are these other 2 measurements. Now, there is a pitfall, and that is pyloric spasm. And that's where, well, I guess the muscle of the pylorus spasms. And so it can become, well, it can appear thickened because it's contracted. So the way to get around this is to observe the infant for a while, at least for 2 minutes. And you want to ensure that there is no passage of the stomach contents through the pylorus during that time. That can be difficult when the infant's moving quite a bit. So if you're not sure, you can get the infant fed so that their stomach is as full as it can be. And that helps a little bit to sort of visualize the pylorus. Right, so assessing the acute abdomen in the neonate can be daunting. So I've included this list to hopefully reassure everyone. There are lots of causes of an acute GI obstruction in the neonate. Most are due to congenital causes, and that can be sort of delineated into high obstruction, of which the main symptom in textbooks anyway is vomiting, or low obstruction, and the main symptom is sort of constipation, and the sort of cutoff is the ileum. So anything proximal to the ileum would be considered a high obstruction. Now, in reality, it can be very difficult because quite often the child will have symptoms that could sort of masquerade as either. But thankfully, very few of these can be picked up on ultrasound due to gas in the GI tract. So really and truly, the diagnoses that you'd be looking for are these ones in red that I've got on the right-hand side. I don't have time to go into every single one, but I'll just give a really short overview. In necrotizing enterocolitis, I'm sure you're all aware that this is associated with preterm delivery. You'll be looking for an echogenic bowel wall as well. We've gone through hypertrophic pyloric stenosis. In ovarian torsion, you'll be looking for an enlarged ovary, a whirlpool sign and reduced blood flow. And in volvulus, the child will typically present with bilious vomiting. You'll get sort of proximal bowel dilatation and a whirlpool sign as well. Now, this next slide just sort of emphasizes what I've just said, but in addition, I'd like to remind you that you will have other assessments as well, because ultrasound isn't usually the first assessment for a child that presents with vomiting. Usually there will be an abdominal radiograph as well, so you will always have that to correlate. You can tell if there is complete or incomplete obstruction from that radiograph, and the child may well have had an upper GI barium study as well. So again, to sort of hammer it home, you're not looking to diagnose absolutely everything under the sun with ultrasound, but really just sort of looking for these particular diagnoses or perhaps sequelae of other events. And that brings us nicely on to case 2. And so the next 2 cases I'm going to talk about are to do with the neonatal abdominal mass. So case 2 was a child who had been born earlier that day. This child was a twin and born preterm at 30 + 2 weeks. They had suffered from twin-to-twin transfusion syndrome. This child in particular was the recipient, and they underwent antenatal laser ligation at 27 weeks. Their prenatal ultrasound showed echogenic bowel and polyhydramnios, and at birth it was noted that this child had a very distended, discolored abdomen and was in significant respiratory distress. The NG aspirates this time were thick and brown. And this is the initial ultrasound image. This was also taken with a linear high frequency probe, and it showed a 5 centimeter well circumscribed mass in the upper abdomen. It had internal echoes, and the rest of the sort of parenchyma of this mass was isoechoic to the liver. Proximal duodenum was seen laterally to it, but the key thing was that this mass was so large in relation to the size of the child that it was difficult to delineate the upper margin, and therefore we couldn't see where this mass was coming from. Helpfully, there was a plain film as well. This shows an appropriately positioned NG tube and the displaced bowel loops with right-sided mass effects. As you can see, the bowel has been entirely shifted over to this side, and we can see no internal calcifications within the abdomen. So that's also, an important negative to look for when you're assessing an abdominal mass. Now, the differential diagnosis of an abdominal mass in a neonate can also be a pretty daunting thing. I've taken this table, it's been adapted from DANET, and I'd like to just hammer home that over 50% of the causes of an abdominal mass in a neonate are to do with the renal tract. So actually, when you're scanning a neonate and the main presenting reason would be an abdominal mass, you want to really sort of look at the kidneys and the entire renal tract when you're doing your ultrasound. That's quite important. This child also underwent MRI, and these are the T2 images. I've shown an axial, coronal, and sagittal slice here. And this was performed to confirm the location of the mass, because as you might remember from the ultrasound, we couldn't find which organ or where this mass was arising from. This shows that the mass was heterogeneous, it looked solid, and it has no calcification. And importantly, it was entirely separate from the kidneys, which were normal, from the liver, which was normal, from the spinal cord, which was normal, and the bladder. So this was actually a meconium pseudocyst, secondary to ileal atresia. Now, this is rare. It's not the sort of thing that you'll see every week at all, but just a couple of points on it. Jejunal atresia and ileal atresia are usually due to an ischemic event in uterus. What you'll be looking for sort of with fetal ultrasonography, and you should have those results, are ascites or polyhydramnios, calcification sometimes, and bowel dilatation. You don't always get all of that. In this case, we didn't have any calcification, but you can sometimes get it. And the neonate typically presents with an abdominal mass, vomiting, and failure to pass meconium. And the way this occurs really is that a sort of sterile or fetal meconium peritonitis will follow bowel perforation, and the inflamed intestinal loops fix to each other, forms an intraperitoneal cyst with a fibrous wall, and the extruded meconium walls off to form a cystic rim calcified pseudocyst. That can be quite large, as in our case here. Now, the value of ultrasound in assessing an abdominal mass. Again, there are some particular things that you need to be aware of instead of thinking that you need to be able to diagnose everything under the sun. The first thing to remember is you've got your initial abdominal X-ray, and that should be suggestive of GI obstruction. And with ultrasound, what you're really looking for is to distinguish whether or not the mass has cystic components or solid components, to evaluate any hydronephrosis, renal cysts, or bladder size. You can identify pyloric stenosis, like our first case, and any ovarian masses. Again, there will be some things that you can't diagnose with ultrasound, but these are the things you should really focus on. And that brings us on to case 3. So the history is quite short here. It was a 1-day-old infant with an abdominal mass. This child was well. They had a normal delivery, an uneventful pregnancy, nothing else of note really. And these are the ultrasound images of the neonate's pelvis with the linear high frequency probe. These pictures were taken of what was assumed to be the bladder, and the report initially read that the mass couldn't be visualized. I think it's very easy to assume that any pelvic sort of fluid-filled structure is the bladder. In retrospect, the bladder was there. And actually there are some sort of points to take home that in a neonate, you'd expect the bladder wall to be uniform, and you wouldn't expect little pockets like this. And always scan up and down and around to try and identify the bladder and whether or not the mass that the sort of fluid-filled structure that you're looking at is the bladder, or whether or not it's something else. There was also moderate hydronephrosis affecting both kidneys. Now, this is important because that suggests that there is obstruction, that there is a big mass, and that something isn't right. So that was another sort of key point to sort of look out for. So in the context of a distended abdomen and a palpable mass and the hydronephrosis, it was decided that further imaging should be performed. This is the chest and abdominal X-ray. It shows air-filled loops of bowel, of which the section of large bowel that extends to the rectum is deviated to the right-hand side by the pelvic mass, and there's no free air at all. Again, this child underwent an MRI, just like in the last case, and this was to delineate where the mass was exactly. And this was pretty instrumental, actually. The MR showed a large cystic septated mass that arose from the inferior aspect of the coccyx. It's sort of demonstrated quite nicely with the sagittal MR here. And it showed that it was an entirely intrapelvic abdominal component, entirely separate from the spine and not affecting the kidneys or the liver. The large mass was causing a bilateral hydronephrosis, and the other pelvic organs, you can see that it was just separate from it. So this was a case of sacrococcygeal teratoma, which is actually the commonest congenital solid tumor in the neonate. And often this is picked up prenatally, which is helpful. So just a little bit about it. These teratomas are germ cell tumors that contain elements from all 3 embryological layers. That means that they can contain fat, they can contain calcification, soft tissue, and cystic spaces. It doesn't mean that they're going to have all of those, but if you see a mass that has sort of various different tissues in it, you want to start thinking about a germ cell tumor. Importantly, I mean, the literature varies, but about 11 to 35% of these can be malignant. Usually the malignant ones are associated with raised tumor markers, but the child may not have undergone any kind of blood test by the time they sort of crop up on your ultrasound list. But they are associated with polyhydramnios, a large uterus for dates, preterm labor because of all of that, and other congenital abnormalities. So it's really helpful to understand a little bit about the antenatal history when you've got an infant presenting with a mass. Plain film features, I suppose, you'll be looking for a type of calcification that could be amorphous, spiculated or punctate, and mass effect. And ultrasound is really to delineate the morphology of this mass. So I've got some learning points for that last case. And I sort of went into them a little bit on the last slide anyway, but you shouldn't really be assuming that every cystic mass in the pelvis is the bladder. I think this is really easily done, and we can all probably think of a case where we did that. So always go back to your first principles of anatomy and figure out what things should look like, whether or not they're in the space that they ought to be in, or whether or not something is abnormal. It might seem strange to suggest further imaging for a one-day-old child, but if you're unable to decipher the origin of the mass, it's actually really important to suggest further imaging, so you can really get a diagnosis early. And also ensure you have access to the notes from the prenatal period, or ask the parents. This child actually had the teratoma diagnosed prenatally, and there were MRI scans, but they were all done at a different trust, so we didn't know, and that could have saved a lot of time. So that's also pretty important. I've got some references here. I'd just like to say thanks very much to Penny and all the registrars who helped with sort of collating the cases, and that's me done. Thank you.
Brilliant. Thank you very much, Priya. In fact, thank you, Alex and Michael as well. Fantastic talks. I think the learning points, especially what's lovely is that you've brought together the learning points of the cases and what you've learned and shared them with us. So that's really helpful and a really good reminder, I think, to everybody. I think, Priya, absolutely the pitfall of is it actually a bladder or is it not a bladder, and any of those sort of cystic masses in the pelvis is really important to think about anatomy. Where are these often big masses coming from? And often the biggest masses can be really difficult to know where they're coming from.